All right, let's do this. Please.
Serious dictation was driving me crazy, so I switched to whisper flow. Here's why I'll never go back. First off,
First thing that we
All right, let's okay, today we are starting CNS pharmacology. I'll be studying using a lecture video here on YouTube, but I'll post often to explain the concepts during the video and highlight some exam relevant questions. If you have any questions, you can ask anytime. Okay, Indian art. Okay, panky sodas. Let's go. Let's go.
What's up, Ninja Nerds? In this video today, we're going to be talking about Parkinson's medications or the pharmacology in Parkinson's disease. There's a lot to discuss. Before we get started, if you guys really do benefit from this video, it helps, you really do understand some things after this, please support us. And the best way that you can do that is by hitting that like button, commenting down the So I think the first thing that we have to do before we can really understand the different names of the medications and the mechanism of action and some of the adverse effects, the classic way that you should talk about pharmacology, we really need to have a good understanding about the basic pathophysiology, the anatomy, some of the pathways that are involved within the circuitry involved in Parkinson's disease before we can really go through the mechanism of action. So let's briefly do that. I don't want to spend a ton of time, so I kind of want to blow through this relatively quickly.
There is anatomy, direct pathway, indirect pathway, the hormones.
If you guys want more detail on this, go watch our video on the basal ganglia where we go over all the anatomy, all the circuitry in way more detail. We're going to kind of go through it a little bit quicker pace to build our foundation though. So when we talk about the anatomy of the basal ganglia, here we have abbreviated PG, there's a couple different structures. One of the first ones that I want you guys to remember here, that I'm going to kind of color here in this pinkish color, is called the caudate nucleus. Okay, so this is called the caudate nucleus. Now, there's a couple other gray matter structures that are just situated deep within the cerebral cortex, right? So here in this area, kind of like the diencephalon, we have another structure that I'm going to draw here in this orange color. So let's do it orange. This is actually going to be the lentiform nucleus, and there's three components of it. This component out here is going to be called the putamen. This one in here, the two components, is called the globus pallidus. There's two parts, the globus pallidus externus, which is going to be this component here, and the globus pallidus internus. So again, let's remind ourselves what these structures are here. Again, we're going to have this whole thing is the lentiform nucleus, and it's made up of the putamen, globus pallidus externus, globus pallidus internus.
Okay, so basically, we are first we need to know what drugs are going to do on the CNS. Yeah, we need to know the anatomy for us to know where the drugs act on. That's what it is explaining, for us to know the parts of the brain where the drugs are going to act. That's why you need the anatomy.
Good. All right, another particular structure, let's draw this one in blue, is going to be these egg-like structures that sit here in the center. These are going to be called your thalami. So each one is a thalamus. So we have caudate nucleus, we have the lentiform nucleus, and we have the thalamus. And again, the lentiform is the putamen, globus pallidus externus, and internus. All right, a couple more structures, almost there. Next one is there's a structure just underneath the thalamus. We're going to draw this as like this box, just underneath the thalamus. This is called the subthalamus. So the subthalamic nuclei are also involved in the structure. And there's one more and super critical to understanding Parkinson's disease. In the midbrain, so here we're in the midbrain, there's these structures here, which we're going to highlight here in black. This is going to be the substantia nigra. The substantia nigra, okay? Now in Parkinson's disease, there is destruction of the neurons within the substantia nigra, which causes a decrease in dopamine. We'll go over all that.
Come on. Hey. Yo. Okay, that was an ad. Sorry. Yeah, let's continue.
But again, a couple other terminologies. So we got caudate, lentiform, which is the putamen, globus pilatus externus, internus, thalamus, subthalamus, and substantia nigra. A couple other terminologies. One is that when we take the caudate and the putamen, we actually do have a particular name for that. And you want to know it's called the striatum. Okay, it's called the striatum. And the reason why I want you to know these two particular structures connected, the caudate and the putamen, called the striatum, is that dopaminergic neurons, which we're going to go over, connect to this striatum. And whenever there is destruction of the neurons in the substantia nigra, it alters the dopamine input on the striatum. And that's where you're actually going to see destructive processes in Parkinson's disease. This pathway is called the nigro-striatal pathway. And that's one of the big pathways that are actually altered in patients who...
Okay, so basically, Parkinson's is like when dopamine levels are not enough and are more than enough, and so because those tremorish and hands. So it's basically highlighting the parts of the brain where dopamine pathways are. That's where the drugs
have Parkinson's disease. Okay, so we got the anatomy down. The next thing we have to do is I want to take this structure here and just kind of zoom in on it. So here's our cortex, here's the lentiform with putamen, globus pilatus externus, internus, thalamus, and then this is going to be the substantia nigra. So this will be, I'm going to put in there, substantia nigra. And then we'll have another pathway. So there's two pathways involved here. One is called the direct pathway, and the other one is called the indirect pathway. But again, we have the cortex, the putamen with the lentiform nucleus with the putamen, globus pilatus externus, internus, thalamus. This is subthalamus, and again we have our substantia nigra. Now you're probably wondering why is there two pathways. Again, if you haven't watched our video on the basal ganglia, I'm going to briefly talk about it here. The direct pathway is a designed pathway to help to play a role within motor movement, particularly desired motor movements. If I want to be able to pick up this, if I want to actually be able to use this particular marker and perform a particular movement, it has to be smooth, I have to be able to initiate it, stop it. All of those fine-tuning types of events are modulated or altered via the direct pathway. Now, if I also want to prevent any unwanted motor movements, like when I bring my pen or my marker into the board from punching it into the board, that's actually going to be modulated via the indirect pathway. So the basic concept is direct pathway wants to help to initiate motor movements and perform desired motor movements, whereas the indirect pathway, it's more of those trying to prevent unwanted motor movements. In other words, if I want to flex here at my elbow, I want the biceps muscles to actually contract and work. I don't want my triceps muscles to be contracting. I want them to relax so that I can allow for that movement to occur. So it's that type of concept.
Oh, come on. I'm sorry, guys. I'm sorry. The ads are so bad. The ads are so bad.
Now, basic concepts of this pathway is really important. From the actual cortex, we have particular neurons, these cortical neurons, and they're actually bringing glutamate down into this area of the putamen as well as the, what else? The caudate nucleus. I got rid of the caudate, so I'm just going to represent the putamen, but that's representing the striatum. These neurons from the cortex will come down and release glutamate on particular neurons located within the striatum. There's also going to be some neurons located here in the striatum, and what happens is these neurons are actually going to be extending from the putamen all the way here to the globus pilatus internus. Now, when the cortex releases, I want you to remember that the red is going to represent glutamate. Okay, glutamate is a stimulatory neurotransmitter. The blue is going to represent GABA. GABA is an inhibitory neurotransmitter. Okay? When actual cortical neurons want to generate a movement, so let's say that my cortex, my motor cortex says, hey, I want you to move your arm. I have to actually consult my basal ganglia, let them know. Say, hey, basal ganglia, this is the motor movement I want to perform. Can you make sure that it's smooth, it's nice, it's not going to be, I have good motor movement that I want to perform and then prevent any unwanted motor movements? Yeah, I got you. Here's how I'm going to do it. So it sends that information down to the putamen. And then what does it do? It releases glutamate onto this particular neuron. What did I say? Glutamate does what? Stimulates. So it's going to stimulate this particular...
So glutamate we know is like the stimulatory hormone, and like glycine, which is an inhibitory hormone. So it's both, we know glutamate pathways and it's explaining the direct pathways and how it's gonna flow, and we'll see how this helps us as we go.
Neuron located in the putamen. Now from this neuron, it's going to extend from the putamen or from the striatum all the way to the globus pilatus internus. And what is it going to release onto the neuron located right here? It's going to release GABA. Now if I stimulated this neuron, it's going to fire. When it fires, it increases action potentials down this neuron and releases lots of GABA onto this neuron. Now this neuron located in the globus pilatus internus extends from there to the thalamus. To the thalamus. But here's what I want you to understand. This neuron released glutamate, stimulated this one. This one's now stimulated. He sends action potentials and releases GABA. GABA does what? It inhibits. So what would be the actual effect here? It would inhibit this particular neuron from firing. Well, then this neuron doesn't fire. Now, what color is it? Think about it. It's blue. So what does it release? GABA. If it's inhibited, is it going to release any GABA? No.
GABA is an inhibitory hormone.
Therefore, is it going to be able to inhibit this particular neuron? No. So now this neuron is released from inhibition. And this neuron in the thalamus, guess what color it is? It's red. So it's going to release glutamate. And it sends this back up to the actual cortex and releases glutamate here on the cortex to stimulate these glutaminergic neurons. Then they'll go out to the particular skeletal muscle and trigger that skeletal muscle to initiate a contraction.
This isn't just any chat, it's ClickUp chat. Sure, you can tag your team, ask.
So this is the direct pathway where cortex to the actual striatum stimulates those GABAergic neurons. They're stimulated, they release GABA. They inhibit the neurons in the globus pallidus internus. If they're inhibited, they do not release GABA. If you do not release GABA, you don't release an inhibitory neurotransmitter. Therefore, you release...
Okay, so you say like glutamate activates this, releases GABA, but GABA here inhibits these globus fighting. So there is no like inhibitory of them.
Release these thalamic neurons from inhibition and stimulate them. They then release glutamate on the cortical neurons and initiate a motor movement. That's how this works. Now, how does the substantia nigra come into this? It's very straightforward. The substantia nigra has particular neurons that extend here all the way up to these neurons in the putamen and the striatum. And it releases dopamine. But the dopamine that it releases it
Substantia nigra up the dopamine
is on a particular receptor here. And I'm going to put it here on the side, but this receptor is called a D1 receptor. Now, whenever dopamine hits the D1 receptors, it stimulates. It works to be what's called a G-stimulatory protein. So it increases cyclic AMP, protein kinases, and then causes cationic influx. And if that's the case, what would it do to this neuron? It would stimulate it like a son of a gun. Now, this neuron, let's make it stimulating here so you can actually see it. So it's going to release a lot of dopamine onto these D1 receptors, stimulate this neuron. If it stimulates it on top of the already stimulation from the glutamate, you're going to have a heck of a stimulation of this neuron. It's now going to release almost no GABA. If it releases almost no GABA, that's going to again, if you stimulate this neuron, it's going to release lots and lots of GABA. I apologize. If you actually stimulate this neuron, it's going to release lots and lots and lots of GABA. That's going to inhibit the heck out of this neuron. Now this neuron is super inhibited. It will not release any GABA. If it does not release any GABA, you're going to release this thalamic neuron from inhibition intensely, and it's going to fire like a son of a gun, send action potentials to the cortex.
Yeah, you see that firing is what now causes those Parkinsonians.
Stimulate those cortical neurons to go and actually stimulate movement very intensely. So what you're seeing here out of the nigrostriatal pathway is what? You're noticing one particular thing, which let's actually do it here in orange. You're noticing that this is going to increase motor movement. That's the whole concept here. You're increasing motor movement. Now, what would it do with the indirect pathway? Very quickly here. You have, again, cortical neurons, same thing. They're coming from the cortex. They're bringing these neurons all the way down to the putamen or the striatum. Again, that's the caudate nucleus and the putamen. Releases glutamate onto these particular neurons here. Remember, glutamate does what? Stimulates particularly. It's a stimulatory neurotransmitter. So it acts on the same neurons located here in the putamen or the striatum. Here's the difference, though. In the directed one, all the way to the globus pallidus internus. We're going to go a little bit of a kind of a little detour, if you will. So now what I'm going to do is I'm going to take this neuron, only go here to the globus pallidus externus. And if I'm releasing glutamate onto this neuron, what's it going to do to that neuron here? It's going to stimulate it. So I'm going to stimulate this particular neuron. It's going to fire. It's going to release GABA. What does GABA do? Inhibits. So if I release lots and lots of GABA, what's it going to do to this particular neuron? It's going to inhibit it. Where does this neuron go to? Subthalamus. So now this is going to come down to the subthalamic nucleus. On the subthalamic nucleus, we have what color here? We have these red neurons. And guess where they go? They go up here to the globus pallidus internus. So you see how we're going to go back to this pathway here. We just made a little detour to the subthalamus. Well, let's keep following here. Glutamate releases on this neuron. There's glutamate released onto this neuron. It's actually stimulated. Releases GABA, inhibits this neuron. If this neuron is inhibited, can it release GABA? No. If it can't release GABA, then what I'm going to do is I'm going to release this subthalamic nucleus from inhibition. And therefore, I'm going to stimulate it. If I stimulate him, I'm going to have this release lots of glutamate onto this actual neuron located in the globus pallidus internus. So this is going to release lots of glutamate. If I release lots of glutamate, what's it going to do? Stimulate this one. This neuron then goes the same direction, goes to the thalamus. And if this is a glutamate stimulating this particular neuron, this neuron's a GABAergic neuron, so it's going to release lots of GABA. What's that going to do to this thalamic nucleus? It's going to inhibit the thalamic nucleus. And if I inhibit that nucleus, then I'm going to inhibit the cortical nuclei that go to the actual muscles, and this is going to inhibit the actual motor movement of undesired types of functions.
Yeah, you see now this what causes the tremor, the muscle inconsistency.
So again, this glutamate is going to release glutamate onto this GABAergic neuron in the globus pallidus internus. It's going to stimulate him. If he's stimulated, he releases lots of GABA. If he releases lots of GABA, he inhibits this thalamic neuron. This thalamic neuron does not release a lot of glutamate onto the cortex. If it doesn't release a lot of glutamate onto the cortex, it will not stimulate the cortical neurons enough, and they won't initiate the motor movement enough. And that could be a good thing for preventing undesired motor movements. Here's where substantia nigra comes in. Again, we have these neurons that actually extend to the striatum, the nigrostriatal pathway. They release dopamine. Now, normally, what you would think, and this is where it's kind of like a little wonky sometimes and confusing, you would think that our substantia nigra, generally the whole purpose of the nigrostriatal pathway is to increase motor movements. That's the whole desire. Increase motor movements. But you would think you'd want to increase the desired movements and then inhibit the undesired movements, right?
Okay. Okay. That's a little interruption there, man.
Right? That's what you would think. Now, that's what it tries to do, but the end result is not effectively the same. So we release dopamine onto this actual nucleus here. But here's the difference. This was a D1 receptor. This one is a D2 receptor. If it's a D2 receptor, that's a G inhibitory protein. That's going to cause potassium ion efflux. That's going to inhibit that nucleus. So you see how substantia nigra is trying to inhibit the actual inhibitory pathway.
What? Oh, yeah, one more.
So we release dopamine onto this actual nucleus here. But here's the difference. This was a D1 receptor. This one is a D2 receptor. If it's a D2 receptor, that's a G inhibitory protein. That's going to cause potassium ion.
Wait, so the one receptor for dopamine is excitatory while D2 is inhibitory? What?
Efflux, that's going to inhibit that nucleus. So you see how substantia nigra is trying to inhibit the actual inhibitory pathway. We want to inhibit the actual undesired motor movements. But when it does that and inhibits this pathway, then what do? Think about this. Keep glutamate the same, but have lots of dopamine, okay? Dopamine is going to inhibit this GABAergic neuron. If it inhibits this GABAergic neuron, what is the GABAergic neuron going to do then? Is it going to release GABA? No. If it does not release GABA, we're going to keep everything black now. If it does not release GABA, what is it going to do to this neuron? It's going to release this neuron from inhibition. So it's going to stimulate it. If this neuron's stimulated, he's going to send lots of action potentials down to the subthalamic nucleus, releasing lots of GABA. If I release lots of GABA onto this neuron, what am I going to do? I'm going to inhibit this neuron. If I inhibit this neuron, I don't release a lot of glutamate onto this neuron. If I don't release a lot of glutamate onto this neuron, I don't stimulate him enough. Therefore, he's inhibited. If he's inhibited, then this neuron doesn't actually go and release a lot of GABA. If I don't release a lot of GABA onto that thalamic neuron, I release that neuron from inhibition, and I cause this action potentials to increase. And therefore, I try to stimulate motor movement. The whole point that I want you to understand out of this is that the nigrostriatal pathway, all it wants to do, my friend, is increase motor movement, whether it be on the direct pathway or indirect pathway. It really wants us to help to be able to perform increasing the intensity of movements. Imagine a patient has Parkinson's disease now. You destroy these substantia nigra neurons. If you destroy these neurons, what's the overall effect going to be, guys? That you'll decrease motor movement. And that is the problem with this particular disease. And sometimes when we decrease this motor movement, it looks at potential ways where maybe if a person wants to move, it's very, very slow. And that could be called what? If it's very slow movement, it could be called bradykinesia. Or maybe they're not really moving very much at all, and it's hypokinesia. Or they're not moving at all in general, and it could be akinesia. So these patients can have a lot of difficulty being able to initiate or perform or stop motor movements. Now here's the other thing that you're probably questioning. You're like, well, yeah, I know that they're slow and they don't move a lot, or they don't move at all, but they got this a lot. They got the tremors and their arms are like lead pipes. What's that from? I got you. There's another, their movements. Now here's the other thing that you're probably questioning. You're like, well, yeah, I know that.
It's going to explain where the tremors come from. So
they're slow and they don't move a lot, or they don't move at all. Well, they got this a lot. They got the tremors and their arms are like lead pipes. What's that from? I got you. There's another potential pathway here that's involved. From the cortex, there is cholinergic fibers. And these cholinergic fibers actually go and release acetylcholine onto these pathways, the direct and indirect pathway. Here's what I want you to remember. Just flip whatever it does to dopamine. Whatever dopamine does in the direct pathway, acetylcholine does opposite. Whatever dopamine does in the indirect pathway, acetylcholine does opposite. So in this pathway, dopamine wanted to stimulate the direct pathway. What will acetylcholine do? It'll inhibit it. So acetylcholine wants to inhibit this particular pathway. That's what acetylcholine. In this one, the indirect pathway, it does opposite. What does dopamine do in this pathway? It inhibits it. So it'll stimulate it. So what you notice here is, in this particular disease, is there's a very interesting pathophysiological process. Let's actually draw our diagram here. That in this particular process, we have our caudate nucleus. This is a good recap, I guess. We have our lentiform, which is made up of the putamen, globus pallidus, externus, internus. We have our thalami. We have our subthalamic nucleus, all of these structures here. And then we have our substantia nigra. What you're going to notice is the basic pathophysiological principle in this disease is that there is cortical neurons, which are going here and trying to interact. There's substantia nigra neurons, which are coming here and trying to interact. And there is acetylcholine releasing neurons, which are going here and trying to interact with this whole basal ganglia, whether it be the direct or indirect pathway. In Parkinson's disease, you have destruction of the substantia nigra, which does what to the dopamine in that striatal pathway. So if I were to zoom in on this particular part of the pathway, which I will here in a second, what is the overarching theme here in this disease? Is that there is a decrease.
Can't trust your AI results? Let Borium sift through 170 million papers and
in the dopamine in the striatum. There's not enough dopamine release in that striatum. On top of that, there's also another thing. Because there is acetylcholine that's actually inhibiting the direct pathway and stimulating the indirect pathway, it's unopposed. If there's less dopamine here, that's going to lead to an imbalance between the dopamine and the acetylcholine. And because of that, there's a decrease in the dopamine, and then acetylcholine is free to be at higher levels unopposed in the striatum. And this imbalance, my friends, is what leads to other effects of Parkinson's disease. Particularly, the decreased dopamine in the striatum is what leads to decreased movement. But the increase in the acetylcholine alters the pathways where that sometimes they're trying to fire at the same time, where the direct and indirect pathway are trying to alternately fire at the same time. And so if you're having your flexors and extensors contracting at the same time, tremors and rigidity.
Yeah.
And so because of that, in these patients, the two particular features in this is that they also have tremors and rigidity. And then associated with this.
So basically, the direct pathway and the indirect pathway, they both fire. Extensive, like in coordination, which causes tremor.
It can also be postural instability, and that could be a combination of many different things. But you get the point here, that that's the basic pathophysiology in this disease. So what my approach to Parkinson's medications has to be is, I got to figure out a way to increase the dopamine in the striatum and decrease the acetylcholine in the striatum to obtain a balance. How do I do that? Let's talk about those drugs. Let's talk about their mechanism of action, and then we'll go over them each in more detail. All right, so what we need to now talk about is what are those drugs? Let's talk about the category of drugs that we can actually utilize that increase dopamine, and then those drugs that actually decrease acetylcholine to restore balance. So with the ones that increase dopamine, you can give one particular drug, and this is called L-DOPA. We'll talk about this one particularly first, okay? It's one of the most commonly utilized drugs for Parkinson's. And basically, we'll talk about how that actually gets worked. Let's actually just kind of list the categories. So the first one is L-DOPA. The second one is I can give something that actually is really interesting, where it's not actually dope, because the whole point is to increase dopamine. So L-DOPA will become dopamine. What if I give a drug that I don't have to use neurons to make dopamine? I just actually allow for it to bind directly to the dopamine receptors. So it's like an agonist, if you will. So let's talk about that one. Dopamine agonist. Okay, so we got L-DOPA, then we got the dopamine agonist. The next one is, okay, I can give L-DOPA, which get converted into dopamine. I can give dopamine agonist, which will act like dopamine on the receptors. What if I give drugs that actually prevented the breakdown of dopamine? And it helped to keep higher amounts of dopamine in the neurons or in the synapses so they can stimulate the dopamine receptors. There's less actually getting broken down. Well, there's two particular drug categories here. One is called catechol-O-methyltransferase inhibitors. We'll talk about these. And then the other one is called monoamine oxidase B.
Yeah, this one prevented the breakdown of dopamine so that it stays and acts for long periods of time.
Inhibitors, and we'll talk about these. The last particular drug category to increase dopamine within the striatum is I can give a drug that actually increases the synthesis or the release of dopamine from the substantia nigra neurons, as well as inhibits the reuptake. So I have more of it getting released and less of it actually being reuptake back into the neuron. So why is that beneficial? Well, if I increase the release and I prevent it from getting taken back up into the neuron, I keep more in the synapse to hit the dopamine receptors, right? So that's the whole concept here. And this is called amantadine. So this is called amantadine, which is its own kind of category, if you will. So that's how we'll target those things to.
Okay, so there is L-DOPA, dopamine agonist, COMT, MAO, and the five classes. The dopamine category of drugs of Parkinson's.
Increase dopamine to be able to improve movement, to increase movement. The other situation is I can give drugs to actually decrease the acetylcholine effect for the tremors, the rigidity, the postural instability, and that's just going to be anticholinergics. So these are going to be my anticholinergics. And we will go over these, such as benztropine and trihexyphenidyl, a little bit later. Okay, with that being said, this is the categories that I want to talk about. What I need to do is, before we can actually understand each one of these drugs and a little bit more about them, I want to have the basic mechanism of action. So what I really want to do is, I want to zoom in on the neurons here in the striatum. And what I really want to do is I want to focus on the substantia nigra neurons acting on that GABAergic neuron here in the putamen, and then the cholinergic neurons acting on that GABAergic neuron in the striatum. So I just want to zoom in on that and then talk about some of the drugs that actually work in that particular pathway. So let's do that. Here we have our diagram. And what we're going to do is we're going to zoom in. So this is going to be the substantia nigra neuron. So we're going to call this one, this is actually going to be the substantia nigra neuron here. This is going to be the striatal neuron. So this is the one that was actually located in the putamen and then the caudate nucleus. And then this one is going to be the cholinergic neuron, which was being released, which was coming from the cortex. All right, so we have an idea here. So this is our schema here of understanding how these drugs particularly work.
Come on.
Now when we do that, let's actually zoom in here. So we know that in order for us to be able to make dopamine, release dopamine, there's a particular process involved. And that's where it's really interesting. So one of the things that happens is we have a particular amino acid that actually can get taken up across the blood-brain barrier. So this is actually going to be, this is representing your blood-brain barrier, which is this capillary kind of like structure. One particular amino acid can get taken up across the blood-brain barrier, and this is called tyrosine. Now what happens with tyrosine is that tyrosine can actually be worked on by what's called tyrosine hydroxylase. Now, when tyrosine is worked on by tyrosine hydroxylase, it actually gets converted into L-DOPA. Oh, well, that sounds familiar. I just talked about that drug over there. All right, cool. L-DOPA can then be worked on by another enzyme called dopa decarboxylase and convert into dopamine. Oh, well, shoot, there it is. There's dopamine. And then dopamine gets put into these vesicles via transporter. And then if this neuron is stimulated and it generates an action potential, the action potential will then move down the axon, stimulate these voltage-gated calcium channels. If these voltage-gated calcium channels are stimulated, calcium will rush into this particular neuron. If calcium rushes into this particular neuron, it stimulates the fusion of this vesicle with the membrane, which then triggers the exocytosis of dopamine. So then dopamine is released. When dopamine is released,
So this is the mechanism of action of L-DOPA. It's basically converted to dopamine, then stored and
it then can move across the synaptic cleft and bind onto this D1 or D2 receptor, depending upon which pathway we're discussing, right? So that's the concept here. Now, once dopamine exerts its effect here, right? So it binds onto this particular receptor, exerts its effects, whether it be via the direct or indirect pathway, we know that. After dopamine is done, then what happens is some of this dopamine actually will go via this special transporter and get reuptaken back into this neuron. So this is let's call this just a dopamine reuptake transporter. Okay, that's how we're going to abbreviate it. Now here's the dopamine. It gets reuptaken back into the neuron, and then from here it can get recycled, as we see the dopamine being recycled here, back into the vesicle and then be utilized again. That's one particular way. The other thing is that some of this dopamine may also go via this transporter. And when it gets taken up via this transporter, it may interact with one of these particular enzymes around the mitochondria. This enzyme here is very interesting because it does not like it to be recycled. Dopamine. And this enzyme is called the monoamine oxidase B. You're like, oh wait, I feel like I just heard of a drug called the inhibitors. Yeah, you'll see how they come into play here. This actually takes the dopamine and breaks the dopamine down. And then now this dopamine is an inactive or kind of like a non-active metabolite. So it has
monoamine oxidase, that's an enzyme that catabolizes it. It breaks down the dopamine into inactive.
No effect. You can't recycle it, so we can't reutilize it anymore. So you see how giving inhibitors would prevent that, and then we can have more of the dopamine being recycled. Very interesting, right? Well, dopamine is not only broken down inside of the actual neurons via the monoamine oxidase B enzymes, it also can be broken down in the periphery, within the synapse. So in the synaptic cleft, there's another particular enzyme which can actually break down the dopamine and break it down into like these molecules. One of the breakdown molecules is inactive metabolite as well. We just happen to call this one 3-OMD. And this enzyme here, which breaks down the dopamine so it actually can't be recycled, it can't be utilized in the synapse anymore, this enzyme is called catechol O-methyltransferase. Wait, Zach, you said there was an inhibitor of that.
So when you inhibit that enzyme, basically you're creating more dopamine left, which is then transported to the other synaptic synaptic plate where it acts there. So basically, when you inhibit the drugs that you are talking about are the inhibitors of these two enzymes, monoamine oxidase catechol or method transferase. So these enzymes they break down the dopamine, but we don't want that. We want the dopamine because that's what we want, so that we can prevent the Parkinson. So we have to inhibit these two enzymes so they don't break down the dopamine. That's what's saying now.
Yep, guess why? Because if I inhibit that particular enzyme, guess what I'm going to do? I'm going to inhibit it from being inactivated into this actual inactive metabolite, keep more of the dopamine either be recycled or keep more of it in the synapse. Man, this is actually making kind of sense, isn't it? Well, we're not done there yet. There's another thing. Here we'll come to the cholinergic neurons last. Here's the other thing. Here's where we kind of run into a problem. So we have particular enzymes out here in the periphery as well. So let's say that I wanted to just give dopamine. I wanted to give dopamine. And if I wanted to give dopamine, I give it into the bloodstream, would I expect it to eventually get taken up into these neurons and then get utilized? You would think that that would be the perfect situation to just give the patient dopamine. Problem is, dopamine can't cross the blood-brain barrier. You want to know how we know that? Because L-DOPA is I told you, that's the #1 agent that we commonly utilize in patients with Parkinson's disease. Let's say I give the patient L-DOPA. So I give the patient L-DOPA. L-DOPA has the ability to be taken up into this particular neuron. And then again, we can bypass the tyrosine and go straight here into this step, eventually convert it into dopamine and then utilize that and increase dopamine in the synapses, right? Well, one of the problems with this is that L-DOPA, only a particular percentage of it can actually get taken up into across the blood-brain barrier. And even less of it can be taken up if there's a particular process. So you know there's another enzymes out here? There's an enzyme out here that actually is very interesting and can convert L-DOPA into dopamine. I wrote it down over here. So there's an enzyme here called tyrosine hydroxylase. This one's called dopa decarboxylase, and these stimulate these particular steps. So what do you think this enzyme is? It's just in the periphery. This is called dopa decarboxylase, and it likes to stimulate the conversion of peripheral L-DOPA into dopamine. Guess what? Dopamine can't be taken up into the across the blood-brain barrier, so I can't utilize that. So I have to give a drug, which we'll talk about a little bit later, to actually inhibit the dopa decarboxylase to prevent it from getting converted into dopamine so that it...
Oh, okay. This makes more sense now. You can't give direct dopamine because it won't cross this membrane, blood-brain barrier. So you can't give direct dopamine. You have to give L-DOPA, which is the only one which crosses the membrane. So to prevent the L-DOPA from being converted to dopamine, you have to inhibit this enzyme. Yeah, dopamine decarboxylase. So that's what he's talking about, that we are going to study other drugs which act on this pathway that prevent L-DOPA from being converted to dopamine, which will now influence its cross into the blood-brain barrier, then to action.
It's pretty much all L-DOPA, so they can be taken across this actual blood-brain barrier. And we'll talk about that a little bit later, but here we already know that L-DOPA can get taken up. Here's another problem. Not only is this enzyme potentially causing L-DOPA to get converted into dopamine, meaning less L-DOPA gets taken out, but there's another drug, or another enzyme. And this other enzyme actually can convert L-DOPA into what's called, this one's actually called 3-MT, apologize. This one is called 3-OMD. Now, you already kind of get an idea here. This was a COMT that converted this into 3-MT, so dopamine into 3-MT. This is going to convert L-DOPA into 3-OMD. And this drug is called COMT. So COMT also converts L-DOPA into this inactive metabolite. It's an inactive metabolite just called 3-OMD. Now 3-OMD is also not able to be taken up across the...
Okay, so yes, you have to inhibit this enzyme to prevent the conversion of L-DOPA to 3-OMD.
Blood-brain barrier. So we can also give drugs, now here's the interesting thing. We can give drugs that can inhibit the COMT enzyme out here in the periphery to make sure more L-DOPA gets taken up. And if we have that drug that also can penetrate across the blood-brain barrier, guess what else that COMT inhibitor can do? Inhibit the central one to make sure that more dopamine is present in the synapses as well. And there is one of those drugs, and we'll talk about, it's called tolcapone. Entacapone is the one that actually only does particularly the periphery one. But here, that's the whole concept I really want you guys to understand, is that L-DOPA is one of those primary drugs that can actually get taken up into the neurons and get used to convert into dopamine. We can actually prevent L-DOPA from being taken up if it's acted on by the dopa decarboxylase and convert into dopamine. This one can't be taken up. So now I have no ability to be able to get the L-DOPA across or the dopamine across. On top of that, if L-DOPA is acted on by the COMT, it gets converted into an inactive metabolite that also can't be taken up. Again, that prevents L-DOPA from getting taken up. We'll go over all of this process when we talk about levodopa by itself. But that's one of the drugs. That's how I get L-DOPA to actually be one of the drugs, because it can actually get taken up, utilized in this pathway to make dopamine. The other one I said was the dopamine agonist. What if I gave a particular drug here that actually works specifically right here? So I actually have it cross the blood-brain barrier, but this particular drug, a dopamine agonist, if you will, I can actually have this drug come and bind specifically right here. If it binds to that actual receptor, it can exert the same exact effect as dopamine on that one. This would be the agonist. This is your dopamine agonist. Okay, and we'll go over the different drugs there, but that's the dopamine agonist. So we already see how we can utilize L-DOPA. So here I'm going to actually put L-DOPA just so we can recognize that this is the first drug that we can actually give, L-DOPA. And we see how it can actually be utilized. It can be taken across the blood-brain barrier and then utilized in this pathway to make more dopamine, right? We can make more dopamine and release more dopamine within the synapse. So there's drug one, there's drug two. The next one we said is the inhibitors, the COMT inhibitors and the MAOB inhibitors. If I gave a particular drug like a COMT inhibitor, it's going to inhibit this particular enzyme. If I inhibit this particular enzyme, I'm not going to perform this particular pathway. So I'm going to inhibit the conversion of dopamine into this inactive metabolite. And therefore, I'm going to allow for more dopamine to be present within the synapse, stimulating these particular receptors. In the same situation, if I give a drug called a monoamine oxidase B inhibitor, it's going to inhibit this particular enzyme. If I inhibit this enzyme, I'm not going to allow for the dopamine that gets reuptaked or the dopamine that's present in the actual axon bulb to get broken down. So I inhibit it being converted into an inactive metabolite. And I allow for more of the dopamine to be present here in the synaptic bulb. So now more dopamine is going to be released in the synapse because I'm going to have more of it being recycled and in these vesicles. And that means more dopamine can bind onto these dopamine receptors. Pretty cool, right? The last one is amantadine. Now, amantadine really does a couple different things. Amantadine works to stimulate the release. So you see this process where the actual vesicles fuse with the cell membrane, it increases that particular pathway. So it wants to increase the synaptic vesicle fusion with the actual, the synaptic vesicle with the actual membrane. And therefore we increase the dopamine.
So amantadine basically facilitates the release of dopamine from the vesicles to the gland. Yeah.
Release into the synapse. That's one particular mechanism. The second mechanism is it also is going to inhibit the dopamine reuptake transporters. Because if I inhibit these dopamine reuptake transporters, I don't actually allow for, I'm not going to allow for as much of it to come into the vesicle, which may sound like a bad thing. But remember, if I bring it into the vesicle, I can recycle it, but I also increase the chance of it being metabolized. If I want more dopamine in the synapses, what if I just inhibit this transporter? So now all this dopamine that's actually was supposed to be in the actual synaptic cleft, it gets reuptaked, right? There's less of it here. But if I inhibit this transporter, now this dopamine will not get taken back up. And if the dopamine will not get taken back up, then more of it is actually going to stay in the synapse and hit more of the dopamine receptors. So that's the concept of these drugs for increasing dopamine. Either give L-DOPA and it'll eventually get converted into dopamine. You just have to be careful because it can get broken down to dopamine in the periphery by dopa decarboxylase or into an inactive metabolite via COMT. So we'll talk about those a little bit later. We can give dopamine agonists that directly stimulate the receptors. We can give drugs that prevent the breakdown of dopamine, like MAOB inhibitors and COMT inhibitors. And we can give a drug that stimulates the synthesis or release of dopamine and inhibits the reuptake to keep more of dopamine in the synapse. The last situation here is the anticholinergics. It's not too hard. Here we have muscarinic receptors, and there's so many different types of muscarinic receptors here present. But I'm just going to put down here that we're going to have muscarinic receptors, and we're not going to go through all the different types. There's 5 different types of muscarinic receptors, right? So because you have these muscarinic receptors, when acetylcholine gets released from these cholinergic neurons, it binds onto this particular muscarinic receptor. And depending upon if it's in the direct pathway, the indirect pathway, we already know the kind of effect that it'll have. If I give a particular drug category here, like anticholinergics, what the anticholinergics are going to do is they're going to inhibit this interaction. They're going to inhibit this particular interaction. So here I want to give anticholinergics because they will inhibit the acetylcholine from being able to exert its effect on the striatal neuron, preventing that excessively high acetylcholine release. So you see now the mechanism of action of these drugs. It's actually really cool. So now what I want to do is I want to go over each one of these drugs. I want to talk about L-DOPA a little bit more. I want to go over dopamine agonists a little bit more. I want to go over these inhibitors and then amantadine. And then lastly, we'll talk about the anticholinergics. All right, so when we first...
what he said, the neuromuscular junction, where you give anticholinergics, that's to prevent the muscle contraction, tremor, which is what we want to prevent.
over dopamine agonists a little bit more. I want to go over these inhibitors, and then amantadine, and then lastly, we'll talk about the anticholinergics. All right, so when we first talk about these drugs of increasing dopamine in the striatum, we're going to talk about L-DOPA first. We already have the understanding of their mechanism of action, but I think the nice thing is kind of recapping this again. Just again, spaced repetition is important to kind of keep going over these things. But the basic concept is that when you give a patient L-DOPA, right, you're going to give it to them orally. When it's given orally, it crosses the GI tract. When it crosses the GI tract, it gets into the bloodstream. So here, L-DOPA is now in the bloodstream. Now, when the L-DOPA is in the bloodstream, we already talked about how there's two particular pathways here. One is we can send L-DOPA into what's called 3-OMD, and this was done via the COMT enzymes, right? We also can send L-DOPA into dopamine, which again, neither of these can cross the blood-brain barrier, and that was coordinated via the DOPA decarboxylase. The whole goal, though, is to get as much L-DOPA as possible into the actual synapse, in this area here, to cross the blood-brain barrier. Because again, we remember that we talked about how we have tyrosine, and then tyrosine is converted into L-DOPA via tyrosine hydroxylase, and then L-DOPA is converted into dopamine via DOPA decarboxylase, taken up into the transporters. If there's an action potential, so calcium comes in, stimulates the vesicles to fuse, and then they release dopamine. And then dopamine gets out here, binds onto the D1 or D2 receptor, and then acts on this particular striatal neuron. We already know all this, right? But what's important to remember is that L-DOPA, right? Whenever you think about this drug, the big things that I really want you guys to remember here with L-DOPA is that L-DOPA is really important because one of the big things is that this is going to be your first line drug. It's your first line drug. Now, preferably, some of the literature will actually say that you should actually go with this one first. If the patient is greater than 65 years of age, if they're less than 65, you can actually use dopamine agonists instead. Again, I just want you to remember it's first line drug. If you want to also remember that on top of that, it's particularly first line in those greater than 65 years of age, but it is going to be your first line drug. Now,
This is your brain when you're struggling to focus. And this is your brain when you're in the zone. But getting in...
Here's the big thing. Because L-DOPA has difficulty in being able to get across the blood-brain barrier because some of it can actually be converted to dopamine, we should oftentimes give L-DOPA with carbidopa. So L-DOPA and carbidopa are often given together. Now you're probably wondering, where the heck does carbidopa come into play? I already have the L-DOPA. I understand how L-DOPA is involved here because it's going to work here to increase or stimulate the increase in L-DOPA. We already know that. Where's the carbidopa come into play? Carbidopa inhibits the DOPA decarboxylase enzyme. So here I have...
Oh my God, I didn't know that. I didn't know that. So carbidopa basically is a DDC inhibitor. The dopamine
carbidopa. And carbidopa works to inhibit the DOPA decarboxylase. If I inhibit the DOPA decarboxylase, I inhibit the conversion of L-DOPA into dopamine. So less of this pathway is occurring, and then I have more of the L-DOPA available to cross the blood-brain barrier. More L-DOPA gets across, you make more dopamine, you release more dopamine into the synapses and stimulate more of the dopamine receptors. Ba-boom, all right? So you see the point here is that carbidopa, if given in combination with L-DOPA, will make sure more L-DOPA crosses the blood-brain barrier because it inhibits DOPA decarboxylase, the peripheral DOPA decarboxylase, okay? And that's also important because the other beautiful thing about carbidopa is it reduces the amount of dopamine in the periphery because guess what? All this dopamine, all right, all this dopamine has the ability to produce adverse drug reactions. So if I give carbidopa, I prevent less dopamine from being in the periphery, and so
those are two advantages. Number one, there's no conversion of L-DOPA to dopamine, which means basically there's more dopamine because L-DOPA is going to be passed through the synapse. Because it's the one that passes the blood. Secondly, the more the dopamine, the more the adverse drug reaction. Now, if you give carbidopa, it's going to inhibit the conversion of L-DOPA to dopamine, which basically means there are no adverse reactions. You will see the adverse reactions.
Carbidopa will effectively inhibit a lot of these adverse drug reactions associated with the high amounts of dopamine that's being converted in the periphery. Isn't that cool? All right. So we have an understanding here. L-DOPA, first line agent, really to be given in patients with Parkinson's disease. If you really want to, sometimes you can wait until they get at least greater than or equal to 65 years of age. It might be more preferred, but it's a first line agent and you have to give it with carbidopa because it inhibits the dopa decarboxylase, prevents it from getting converted into dopamine. Dopamine can't cross the blood-brain barrier. So you get two effects out of that. One is you make sure that you have more L-DOPA to cross the blood-brain barrier and be utilized, and you have less dopamine in the periphery to cause adverse drug reactions. Now, with that being said, what are some of the adverse drug reactions that you can see? Well, one is that if there is a lot of this dopamine present, dopamine has a very profound cardiac stimulation. So I want you to think about pretty much elevated dopamine is really the problem here. So elevated dopamine, what it can do is it can really stimulate the heck out of the SA node and AV nodal system. So it might make it fire a lot more. And if it makes it fire a lot more, you're going to see a very profound increase in the patient's heart rate. So you're going to watch out for tachycardias or tachyarrhythmias in these patients. The other thing is that there's dopamine receptors that are very profoundly found on veins, which is really interesting, right? So there's lots of dopamine, especially D2 receptors, that are present on our veins. And what happens is when dopamine binds onto these particular receptors, it causes vasodilation. So it vasodilates. If you vasodilate, you decrease the systemic vascular resistance. Or actually, I would actually, more specifically, not systemic vascular resistance, you do decrease resistance, but you don't squeeze the vein. If I don't squeeze the vein, I don't squeeze as much blood into the heart. So I reduce my venous return. That reduces the stroke volume, and that can actually cause the patient to develop orthostasis. Because whenever they go from one position to another, they don't have adequate venous return. And because of that, this can lead to orthostasis. So whenever the patient stands up or goes from a seated to a standing position, it can stimulate this orthostatic mechanism because it vasodilates the veins very profoundly, okay, via the D2 receptors. And then also, there's dopamine and beta receptors that are present on the cardiac system, particularly the nodal system, and they may see a tachyarrhythmia associated with that. So watch out for tachycardia and watch out for postural hypotension or orthostatic hypotension. The other thing, lots of dopamine is also interesting because when you have lots of dopamine, there's particular things that you want to remember, that there's a lot of different dopaminergic pathways besides the nigrostriatal pathway, right? So here's our nigrostriatal pathway that we already talked about going from here to the basal ganglia. We also have pathways that can actually go and connect to the limbic system. So here I'm just going to draw these here in like green. This is just going to be my limbic nuclei. And this could be a lot of different structures, the amygdala, the hypothalamus, the mammillary bodies. There's so many different structures, but this is called the mesolimbic pathway, right? So you have something called the mesolimbic pathway. And this is a pathway that's associated with your emotions, your reward, your thought processes, a lot of those things. So because there's lots of dopamine that's being released within the mesolimbic pathway, that can cause a lot of like actual emotional issues. And so some of the things that you can see because of this is you can start seeing very nasty types of effects here. It can start off where the patient has like anxiety, and then it can actually bridge pretty significantly. And it can move to things like delirium. It can move to things such as hallucinations.
Delirium is when you are so like, you are angry.
Delusions, which is terrible. And then
Hallucinations, we know those are delusions you are seeing things that are not there.
even progress all the way into like psychosis.
Psychosis.
Work today is broken. Every day, people juggle so many different tools just to get work.
So because of that, that's kind of a scary thing to think about here, is that you really want to watch out here for nasty adverse effects via the mesolimbic pathway. When there's lots of dopamine released within this pathway between the substantia nigra and also all the way connections into like the limbic nuclei, like the amygdala, like the hypothalamus, like the mammillary bodies, like the cingulate gyrus, all of these different structures here, it can lead to increases in anxiety, delirium, hallucination, psychosis, even sometimes impulse control. So watch out also for impulse control and impulse control. Something like gambling, not even kidding. Sometimes it can just cause a lot of like loss of inhibition. So these are big things to think about with this. There's one more interesting thing. You know, there's a center here located within the medulla. Let's draw this one here in pink. So this is a center here located within the medulla, and this is actually called the chemotrigger zone. So what is it called? It's called the chemotrigger zone. Now the chemotrigger zone has lots and lots of dopamine receptors present on it. And so...
Hey, I didn't know what the CTZ meant. Chemotrigger zone. Okay.
We can actually use particular drugs to actually block those dopamine receptors when people are feeling like kind of nauseous or vomiting. But if you have lots and lots of dopamine, that's lots of dopamine binding onto these chemotrigger zone receptors, the dopamine receptors present on the chemotrigger zone, which guess what that's going to do? If you stimulate the chemotrigger zone or the emetic center, that's going to cause these patients, you're stimulating the emetic center, this will trigger nausea and vomiting. So another particular thing to watch out for in these patients is another adverse effect here is nausea and vomiting due to lots of dopamine stimulating the chemotrigger zone, leading to the activation of the emetic center in the medulla, leading to nausea and vomiting. All right. So we now know that increasing dopamine can cause cardiac stimulation, postural hypotension, can stimulate the mesolimbic pathway, causing a lot of like psychotic or delirium type of effects, and cause a lot of nausea and vomiting via the emetic center in the medulla. You know, the interesting thing is a lot of these drugs that are increasing dopamine in the striatum, whether it be decreasing its breakdown, whether it be acting like a dopamine agonist, whether it be whatever, all of the drugs that we talked about that increase dopamine, guess what? All of them can have these types of effects, which is important to remember. The next things that I want to talk about here is the effect of that there's way too much dopamine because you give way too hefty of a dose, or maybe because you're having a patient who's taking levodopa and carbidopa with another drug that just increases too much of the dopamine in the synapses. Either way, there's just way too much dopamine present in the striatum. What's another negative side effect? Because generally it can increase movement. What if it increases movement way too much? Let's talk about that. All right, so we already talked about all of these pathways here, but the basic concept here is that we had, again, the nigrostriatal pathway, which is the dopaminergic pathway from the substantia nigra connecting to the neurons in the putamen or the striatal area, right? And we already know that there was particular neurons here that we already discussed, that it could go in two pathways. One, it could be the direct pathway, right? The other is it could go via the indirect pathway. And the whole concept here is the same. That whether it be the direct or indirect pathway in this situation, what we know is that dopamine works to be able to, if it's the D1 receptor, to stimulate the direct pathway, or if it's the D2 receptor to inhibit the indirect pathway. We know the overarching theme that we already talked about above is that it does what? It increases movement, right? That's the whole concept, and that's the whole beauty of this, and that whenever you are increasing movement, that's supposed to help patients who aren't really moving a lot at all. But what if you give way too much of a dose? Way too much. So there's just way too much dopamine. Whether this be such a high dose of carbidopa and levodopa, whether this is because you're giving L-dopa and something else that's increasing dopamine in the synapse, like you give it with a COMT inhibitor, you give it with an MAOB inhibitor, you give it with a dopamine agonist, you give it with a amantadine, all of those things are going to bring too much dopamine into the striatum. So all in this area here, there's just way too much dopamine. That's going to increase the firing way too much. And so now you get an abnormal increase in movement to the point where it's actually pathological. You'd think it'd be beautiful, but no, this is a problem. And whenever the movements are so intense, we call this dyskinesia. And what could this look like? There's so many different ways that it can look like. Some of the things that you want to think about here is that sometimes the patients can exhibit things like chorea. So they have just like this unorganized type of movement where they can't control it. Or they have things like athetosis, so they have kind of like a snake-like movement of their fingers. They can't sit still, so they have akathisia, they're super restless. These are potential things that we're seeing because you're causing way too much stimulation of the indirect pathway. And a lot of the extrapyramidal symptoms are starting to develop. So watch out for this. This is one of the things that you can see really with high levels of dopamine, whether because you give too much L-dopa or
Too much L-dopa, too much, or a combination of L-dopa with MAO inhibitor come to because all these adverse reactions, chorea, athetosis, akathisia, dyskinesia.
whether it be L-dopa plus something else that increases the dopamine in the synapse, like a dopamine agonist or a COMT inhibitor or an MAOB inhibitor. You get the point. It's one of those potential concepts that you're seeing here. All right, my friends. So we have dyskinesia as another potential effect. There's one more thing that I want to talk about. It's actually really important that you may see on your exams. Whenever patients are given L-dopa, they can experience something called the on-off phenomenon. And it is very straightforward. The concept behind this is that if you think about it, patients who have Parkinson's disease, right? So let's say here we have just a small quick diagram here. As you think about this, here's our substantia nigra, right? There's neurons that are supposed to go and connect to the striatum.
Come on. Ugh.
Right? That's the whole concept. As you have Parkinson's disease progressing and progressing and progressing, what happens to the number of substantia nigra neurons? They decrease. So as the disease continues to progress, there is a decrease in the number of substantia nigra neurons, which means that there's less neurons available for dopamine use. So not only does it mean less dopamine, but that means even if you give a drug like L-dopa, if there's less neurons, you don't have the nerve terminals to use. Because remember, what does L-dopa need? It needs the terminal to actually get converted into dopamine, get put into the synaptic vesicles, the neuron to be stimulated, then to release it. So that's a problem. Even though I give patients L-DOPA, I need a certain number of neurons present to actually utilize the L-DOPA to make dopamine. Do you understand what I'm saying? So because of that, what we start seeing is we see this effect where, let's say that I give the patient the drug. I give them L-DOPA, carbidopa. They take the drug, they see a particular effect of the drug for so many hours. Then the drug starts wearing off. And then what happens? Their symptoms come back. So you give them another part of the drug, right? As the neurons start becoming destroyed and destroyed and destroyed, you have less dopaminergic neurons available for L-DOPA. So these symptoms start actually developing a lot quicker. And so patients will take the drug, they'll have this period where they're on, right? So they're having good improvement in mobility, they're doing everything, they're moving well, but then the drug starts actually wearing off very quickly and they go into this off phase. So then they have akinesia, where they're not moving at all, and they're at risk for like pneumonia, aspiration, DVTs, all that stuff. Or they're just moving very, very slow. So they're going back, they're kind of resulting back in their Parkinson's phase. And so what do you have to do? Then you have to either give a higher dose. But what's the problem with that? So think about that. All right, here's our dose response curve, right? So here is my maximum efficacy, my Emax, right? You guys remember this from the pharmacodynamics lecture? In Parkinson's disease, what we see with the off phase where it happens is we see there is a decreased number of substantia nigra neurons, meaning there's less neurons available for dopamine. Even if we kept the dose the same in this patient, when they're in the off phase, they're wearing out, okay, the drug's wearing out, what we notice is that even at the same dose, we notice a decrease in the Emax. Look at the Emax now.
Imagine conducting every part of your research only on one platform. Meet Boreum.
The Emax has decreased. So in this situation here, we notice a decrease in the efficacy of the drug. There's a decrease in the efficacy of the drug. And the reason there is a decrease in the efficacy of the drug is because the number of neurons are decreasing and they don't have enough neurons available to be able to use the L-DOPA to make dopamine. So what would you think? Well, what I could do is if I increase the dose, that would work, right? So let me go ahead here and just jack up the dose. So now here, on the x-axis is the dose, on y-axis is the response. The response is dependent upon the L-DOPA, the dose of L-DOPA, but it's also dependent upon the number of neurons. That's what we got to remember. I can't change this, but I can change the dose. And so you think, oh, here we go. Here's what I'll do. I'll increase the dose, and if I increase the dose, I go this way, maybe I'll get to that maximum efficacy. But if you guys remember from our pharmacodynamics lecture, yeah, we may get to that max efficacy, but as I start working farther and farther and farther down this dose range, what do I increase the risk of? I increase the risk of these toxic doses. So now I start getting into the realm of negative side effects, because as I increase the dose of my L-DOPA, I'm going to see more of the dopamine in these synapses. I'm going to see more of the dopamine effect on the heart. I'm going to have more of that dopamine in the mesolimbic pathway, more of the dopamine, see more dyskinesias. So as I increase the dose, I'm going to see increase in the toxic adverse drug reactions. So I can't increase the dose too much. I may be able to increase it a little bit, but what could I do instead to keep the dose the same so I'm not having so much L-DOPA getting converted into dopamine? What if I keep the dose the exact same, but I give it more frequently, right? So in patients who have what's called the on-off phenomenon, so let's actually write this here, the on-off phenomenon, which is basically on is when the drug is working. It's working in those actual synapses, it's getting taken up by the neurons, it's working to be able to improve their symptoms. Then as the drug wears off, which can start occurring really, really quickly, as the number of neurons are becoming less, this off phase will come on very, very quick. So the drug won't last very long. And so because of that, you think, oh, well, the efficacy is decreasing. If I increase my dose, I'll increase the efficacy. Yes, you will, but then you end up with toxic adverse drug reactions. So the ways that I can prevent the off phase, preventing the drug from wearing off quickly, is I could do a couple things. One option here is I decrease the time intervals. So instead of me giving it, I'm just making it up, every 3 hours, every 6 hours, I give it every 3 hours. So I increase the frequency of the drug dosage. Here's one other option. Another option is maybe I give this drug, L-DOPA, in combination with something else that prevents its breakdown or acts like it. It just doesn't cause as much L-DOPA to convert into dopamine. So I give something else besides L-DOPA. Oh, that's a great idea. So let me give L-DOPA plus something that will not actually cause L-DOPA to get converted to dopamine. So anything else, anything. I can give it with a dopamine agonist. I can give it with a COMT inhibitor. I can give it with an MAOB inhibitor. You get the point here. I can give L-DOPA and carbidopa with any of the other dopaminergic drugs, because what that's going to do is it's going to help to be able to either increase dopamine in the synapses or have a drug that acts just like dopamine.
Let's leave it. Let's leave it there. Continue. environment.